All right, so the objectives of the talk are to review the mechanical complications of acute MI, to demonstrate the echo findings in mechanical complications, and to just broadly talk about acute management in these patients. So to categorize them, I like to think of them as non-rupture or rupture complications. Non-rupture complications are listed here. You can have ventricular failure, aneurysms, thrombus, functional mitral regurgitation, and LVOT obstruction. And then you can have rupture complications, which include papillary muscle rupture, ventricular septal rupture, and free wall ruptures. So left ventricular failure is the most common cause of low cardiac output heart failure. It can progress to cardiogenic shock if you have more than 40% of the LV being infarcted. And the risk factors for developing cardiogenic shock are listed there. If you have LAD, territory infarcts, multivessel disease, or left main disease, if the LV has been insulted multiple times, so prior MI, or early use of beta blockers can push these patients into cardiogenic shock. The management, we deal with these every day. So broadly speaking, in the acute setting is to reduce, you're trying to offload the left ventricle as much as you can. So you reduce the afterload using vasodilators. You reduce preload by diuresing these patients. And if it's bad enough, you can give inotropy. The main echocardiographic features that we're looking for are systolic dysfunction and regional wall motion abnormalities. There's different ways to measure that. What we most commonly use is Simpson's biplane, but there are fancier ways of doing it, like 3D echo, and but the main thing we're looking for is the systolic dysfunction in these patients. This is an example of an anterior STEMI. So on the top right, we have a peristernal long axis, and we can see that the anteroseptal wall is down. So it's showing the apical four chamber, and this is showing the short axis view at the mitral, at the papillary muscle. And again, we can see that the anterior and the anteroseptal wall is magnetic essentially. Okay, moving on to right ventricular failure. So RV infarcts happen because of ischemia to the right ventricular marginal branch. The most common scenario is a proximal RCA occlusion. RV infarcts represent about 1/3 of all inferior STEMIs. The presentation is, these patients usually are quite hypotensive. They have JVP distension, clear lungs, but they may still have hypoxemia just from the increased right-sided pressures. And some of these patients, they have PFO, so if you have shunting from the right to left, you can also contribute to the hypoxemia. The main issue here really is that there's poor cardiac output from the right heart to the left heart, so the left ventricle is underfilled. So in this case, you want to promote that cardiac output, so you're actually trying to give fluids if the hypotension is bad enough. You try to increase RV contractility. Milrinone is a good option here just because not only does it increase contractility, but it also reduces the pulmonary arterial hypertension or vasodilates the pulmonary vasculature. So it can reduce the RV afterload. And finally, you try to prevent systemic hypotension. Vasopressin can be a good choice here just because it preferentially acts on the systemic vasculature, so it doesn't increase RV afterload. Okay, so how do we actually assess these patients echocardiographically? Like anything in echo, there's both visual and quantitative measures of or assessments. So visual assessments include RV dilatation. You're looking for wall motion abnormalities. So a very specific sign for RV dysfunction generally is what's called the McConnell sign. So we're looking for free wall akinesis and preserved apical contraction. So it's preserved apical contraction, but it just looks that way. What's actually happening is the left ventricle is contracting, and it just makes it looks like the apex is contracting. You also have septal flattening, so indications of pressure or volume overload. IVC dilatation, which is just a reflection of increased pressures in the right ventricle. Okay, so in terms of quantitative assessment, the two most common ones that we typically use in the cath lab are TAPC and tissue Doppler imaging of the tricuspid annulus. So the idea is that when the right ventricle contracts, the tricuspid annulus moves in the cardiac cycle, and by measuring the distance that it moves or the speed at which it moves, you can get a sense of what the systolic function of the right ventricle is. So each of these are studied in the general population, and there are cutoffs that suggest systolic dysfunction. That's what we most commonly use. But there's also other measures like global longitudinal strain, which generally speaking is a measure of the degree of change in length of a particular segment of myocardium. And if there's an infarcted area, that degree of change will be minimal. So that can be used. There's also the fractional area change, which is kind of like a poor man's Simpson's biplane. But instead of a biplane, you're using just the apical four chamber, and you're trying to see the difference between the area of the right ventricle, systole, and diastole. It doesn't work quite as well just because the right ventricle is not cylindrical or not conal shaped, but a cutoff of 35% is used. Okay, so this is an example of an inferior STEMI. So over here we have a peristernal short axis at the level of the mitral valve. We can already see that the left ventricular cavity is much smaller compared to the right ventricular cavity. We can't see all of it just quite yet. But you'll notice that during diastole, there is flattening of the interventricular septum. So indication of right ventricular volume overload. Also notice that the basal, inferior, and ventral septal segment is not moving as well as the rest of the segment. This is showing the same thing at the papillary level. And we're seeing now that the right ventricle come into view. Again, it's dilated, and the free wall is not moving at all. It's showing a similar thing in the apex. Okay, so this is the same patient. Now we're looking at the apical four chamber with the RV focus, and we can see that the free wall is not moving, but the apex looks like it's moving. So this is an conal sign. When we try to do tricuspid or tissue Doppler, we get a measurement of 8 centimeters per second, well below the cutoff of 12. And when we do the TAPC, we get a measurement of 1.2 centimeters, well below the cutoff of 16 to 18. So there's multiple indications here that we have RV dysfunction. We have RV dilatation, septal flattening, wall motion abnormalities, and measurement abnormalities. So in the context of an inferior STEMI, this is pointing to an RV infarct. Okay, moving on to aneurysms. So aneurysms can happen both in the left ventricle and the right ventricle, but LV aneurysms are much more common. So this represents basically what we're referring to is an infarcted area in the left ventricle that becomes thinned over time, scar develops, becomes thinned over time, and becomes dyskinetic eventually. So usually it's anterolateral apical wall infarcts that causes, just because there's poor flow there from collaterals. These have a low risk of rupture. This is a diagram of what we're talking about. So this is the infarcted area. Over time, this area becomes thinned and it develops a cavity. So the consequence of this is that it's very mechanically disadvantageous. So when the rest of the myocardium contracts, the stroke volume normally the stroke volume is all towards the aorta. But when you have this cavity forming that's not contributing to any contraction, there is blood that's going into the cavity, and it results in higher heart failure. Also, because there's stasis of blood in the cavity, you can have thrombus development. And because there's lots of scar here, you have VTs, ventricular tachycardias. Typically, the management of these patients is to medically manage them for their heart failure, and if thrombus is present, you anticoagulate them. Surgery isn't usually required, but sometimes these patients can have refractory heart failure or refractory VT, and in that case, you can consider surgery. The main echocardiographic echo features that we're looking for are a thin segment of the left ventricular wall that's dyskinetic. It's a deformity that we see both in systole and diastole. And we're looking for a wide base, so the base of the cavity is quite wide. Okay, so this is an example of an aneurysm. We have a parasternal long axis view here. The anteroseptal wall is not moving well at all, and we can't really make out what's in the apex from this view. When you look at the apical forechamber, you can see that the cavity narrows and then it dilates quite a bit into in the apex, and if you pay attention, it's actually dyskinetic there. And you wonder whether there's something there. We can't, there's shadow here. We can't really make out what's in that very distal apex. Okay, so moving on to thrombus. So this wouldn't be a St. Michael's talk without a sprinkle of mentioning a deceased distinguished gentleman. So we have Mr. Dr. Rudolf Virchow here. He was a prominent pathologist in Germany in the 1800s. He had a number of contributions to science, including cell theory. He created the tenet that all cells are derived from other cells. He was a big public health advocate, particularly in the fields of hygiene and sanitation. And he created, or he described, the features that you need to have development of thrombus in the body. So this is Virchow's triad, and it refers to the three conditions here are inflammation or a hypercoagulable state, endothelial injury, and stasis of blood. All myocardial infarctions have endothelial injury and inflammatory hypercoagulable state, but not all MIs will have stasis of blood to the degree that you need to develop LV thrombus. So LV thrombus, depending on where you look, it can be as low as 4% to as high as 39% after STEMI, and that all depends on the era that you're looking at and the modality that we're using. But 10 to 15% is a number that we see with echocardiography. And most commonly, they happen within 2 weeks of an MI. There's a high chance of embolization, and stroke is the most common presentation. The risk factors are a reduced left ventricular ejection fraction, apical akinesis, and anterior MIs cause both of those things. So when you're looking at an acute thrombus, the sensitivity to pick it up is about as high as 60%. When you add contrast, that sensitivity goes up to about 90%. And then there's also chronic thrombi, which have a very different characteristic. They're calcified, they're layered and laminated and organized. We'll discuss. So this is a schematic showing the differences between acute and chronic. In the upper panels, we have no use of ultrasound enhancing agent, and in the bottom we have ultrasound enhancing agent, so Infinity. But in the looking at the top left panel here, in the acute setting, what we're looking at is a protruding mass into the left ventricular cavity. Now you can imagine, so this is a fairly large thrombus, but you can imagine if this was a smaller thrombus in the same patient, you wouldn't be able to see it just from that shadowing there. So that's why the sensitivity is not as great. But when you add ultrasound enhancing agent, you can see that there's percolation of the contrast around the mass, and that's what we look for to characterize it as a thrombus. When we look for chronic thrombi, it becomes a lot more calcified and layered, following the contours of the left ventricle. And the key features are that there's a bit of a sharp demarcation from the normal myocardium to the thrombus. When you add contrast, you can see that the contrast it percolates into the myocardium, but doesn't do the same with the thrombosed areas. So that's also a clue. So the main things are sharp change in angle or flattening and percolation of the contrast into the myocardium. So this was the earlier case of left ventricular aneurysm that we were looking at. So when you add contrast to this patient, you see that there's the contrast is not percolating into the myocardium in the apex as well, and there's a sharp demarcation here. There's a flattening that's unusual, and that's suggestive of a chronic thrombus. This is an example, another example just to highlight the point. These are the apical shots after a distal LAD occlusion. We can see some apical hypokinesis, but difficult to make out thrombus. You could call these trabeculations, but can't say for sure that there's thrombus here. When we use contrast, though, in the apical forechamber, again, it's still not obvious. You start to see something flopping in and out in the apical 2 chamber, and finally in the apical 3 chamber, it's a lot more prominent there, where you can see the contrast is going behind that little mass, and that's LV thrombus. Okay, so how do you treat these patients? This was the proposed algorithm by AHA. So when you see a thrombus, you want to anticoagulate these individuals with dual antiplatelet and an anticoagulant for at least 3 months. But what if you don't see a thrombus and there are high-risk features of thrombus development, so apical akinesis or low ejection fraction? In that situation, you want to get a TTE within 72 hours with contrast to see if it's there. If it's negative still, then they reckon the proposal here is to do a repeat TTE with contrast within 2 weeks to rule it out. Okay, so that's the treatment there. Moving on to LVOT obstruction. So this is a very rare complication that can happen with apical infarcts, so what happens is the apex becomes akinetic, and you have compensatory hypercontractile base. So that's a perfect recipe to develop LVOT obstruction, and these patients present with heart failure symptoms. The treatment is the opposite to conventional heart failure. You're trying your best to open up the left ventricular outflow tract, so you try to increase the afterload and increase the preload gently. You avoid inotropes because that'll just make the hypercontractile base worse, and it can worsen the LVOT obstruction. So the interesting thing here is that the diagnosis is made entirely by echo, and what we're looking for is systolic anterior motion of anterior mitral valve. And with that, you have mitral regurgitation that accompanies it. So this is an example of an apical infarct with a systolic with SAM. And if you look closely, when there's systole, there is movement of the anterior mitral valve into the LVOT. And when you put color over it, you can see that there is a puff of regurgitant jet posteriorly directed. So all this is pointing to SAM and LVOT obstruction. This is another example, but this is a little different in that the anterior mitral valve is not moving in systole. It's closed, but there's something popping in and out during systole. So this is an example of chordal SAM, but same pathophysiology. The other thing that you try to look for are increased gradients across the LVOT, and you're looking for a late peaking gradient that worsens with Valsalva. So if you see this, if you've seen gradients increasing with Valsalva, late peaking, that is highly suggestive of LVOT obstruction. Okay, so that's that. Moving on to functional mitral regurgitation. So this is a particular problem where we have remodeling the posterior basal segment that leads to apical displacement of the papillary muscle and causes mitral regurgitation that way. So I'll try to demonstrate this with a diagram. So over here we have a normal left ventricle. We have a papillary muscle that's connected to the mitral valve through cords. And when there's a posterior basal infarct, you can have remodeling that leads to apical displacement of the papillary muscle in such a way that it pulls on the posterior leaflet more so than it does on the anterior leaflet. And that leads to malcoaptation, which causes a mitral regurgitation. So it's often described as a pseudo prolapse of the anterior leaflet because it looks like it's behind the posterior leaflet, but it's not behind the annulus. So what's actually happening is there's tethering restriction of the posterior leaflet, causing the malcoaptation. So the echo features that we're looking for really are basal to mid inferior infarcts or motion with remodeling. And you can see this in just generally LV dilatation as well. And we're looking for tethering restriction of the mitral valve leaflet. I couldn't find an example of this entity, but this is an example of functional mitral regurgitation, where the entire left ventricle has been dilated. There's severe dilatation of the left atrium here. And when we focus on the mitral valve itself, we can see that the posterior leaflet is more directed to the apex than the anterior leaflet. There's no prolapse here, but there's restriction of the posterior leaflet. And then when we put color over it, we can see that there's a posteriorly directed jet. So this is functional MR. Okay, moving on to the rupture complications. So that was all the non-rupture stuff. So just a quick word on rupture complications. They have a very, very high mortality rate. Before the advent of revascularization therapy, the mortality from the incidence was about 1.7%, and the mortality was as high as 70%. So dismal prognosis. But with the advent of fibrinolysis and primary PCI, the incidence has dropped by about half, but the mortality still remains extremely high. So we'll start off with papillary muscle ruptures, and it's worthwhile to just go over a bit about the anatomy of the mitral valve. So it's a complex structure that involves the mitral valve leaflets and the subvalvular apparatus. So the mitral valve leaflets are divided into three, as shown here, and they are connected by cords to the papillary muscles. We have two muscles, and each has multiple heads, can have multiple heads. The interesting thing is that, so the anterior lateral papillary muscle has dual supply. It's supplied by LAD and circumflex, whereas the posterior medial papillary muscle has single coronary supply. So it's either the RCA or the left circumflex. So you can imagine that this is much more prone to injury compared to the anterolateral papillary muscle, and that's borne out. I'll point out that when you have rupture of the posterior medial papillary muscle or any of the pap muscles, it can be a partial rupture, it can be a complete rupture. Because it's tethered to both the anterior leaflet and the posterior leaflet, it's difficult to predict exactly which leaflet will flail, but you're looking for a prolapse or a flail of the mitral valve leaflets. Okay, so the incidence of this is about 0.1 to 0.3%, and the mortality is very high, up to about 40%. Also important to mention that it is a subendocardial structure, so you can have rupture happening with end STEMIs as well as STEMIs. These patients present quite dramatically, so they present in flash pulmonary edema, quite shocky. There may or may not be mitral regurgitation murmur present, just because of the rapid equalization of the chambers. There may not be enough turbulent flow to auscultate. The treatment really is surgery, You try to temporize the patient by reducing the afterload. It reduces the amount of regurgitation. You also try to reduce the preload. And balloon, like mechanical support is necessary, and balloon pumps can help. All right, so the echo features that we're looking for here are prolapse or flail, like in this case, where the tip of the mitral valve is pointing into the atrium. You're also looking for a mobile mass, which is a representation of the ruptured papillary muscle that's moving in and out of the left ventricular cavity. Sometimes it can even go into the left atrium. And then we're looking for severe mitral regurgitation. So this is a shot of eccentric, like posteriorly directed mitral regurgitation that's quite prominent. But in real life, it's often not as impressive, just because of how rapid the equalization happens. What you do see, though, is that when you do continuous wave Doppler over it, the profile is quite dense, and you have early peaking with an asymmetric triangular shape, all suggestive of very rapid equalization pressures. Okay, so this is an example of a papillary muscle rupture. These all the cases that I tried to find, the views were not great, and it makes sense. These patients are quite sick. They're on BiPAP, intubated, and difficult to get views. But this is, well, if you see in the left ventricular cavity here, there is a structure popping in and out, and that's the ruptured papillary muscle. You can't see the mitral valve leaflets that well here. This is looking at it in the short axis, and again, we can see that the papillary muscle is just flopping the posterior medial rupture. You can also see that there's essentially akinetic posterior and posterior medial left ventricular wall. All right, so moving on, this is just another example where we see the mitral valve better. You can see that there is, pay attention, you can see the flail of the leaflet here. When you put color over it, we can see if there is turbulent flow and there is regurgitation, but this is what I meant. It's not quite clear, it's not obvious the way it is in that picture. But if we were to put color up or continuous wave Doppler, we would see a very dense jet, or a dense profile. Okay, moving on to ventricular septal ruptures. This is the most common complication of acute, most common rupture complication of acute MIs. The mortality is very high. There's different kinds that you can have. So there's distal apical ventricular septal ruptures that are consequence of wraparound LADs. Or you can have basal ventricular septal ruptures that are more consequence of occluded RCA and PDA. The way these patients present is that they have a very harsh systolic murmur. That's a reflection of how big the defect is. The smaller the defect, the bigger the louder the murmur. It can be quite shocky, and they can have dyspnea just from the increased pressures. The management is, again, you call cardiac surgery, and then you try your best to offload the right ventricle. The whole problem here is that there's shunting of blood from the left ventricle into the right ventricle, and anything that can reduce that shunting is helpful in the acute setting. So nitroprusside is very useful here. You also try to decrease the preload by aggressively diuresing, and balloon pumps are helpful. The main thing so it's the visual defects for ventricular septal ruptures, with like other ruptures as well, they're difficult to visualize, so you do try to look for clues. You can try to put Doppler across the RVOT and look for increased flows, and look for VTI. If there's a suggestion of increased flow, then you can start investigating further. You may or may not see dilatation of the pulmonary artery and the RV, just depending on how acute the situation is. The main feature that we're looking for is really the ventricular shunt. So you can either use color or contrast to demonstrate that. And of course, we're looking for wall motion abnormalities. So this is an apical four-chamber of an apical infarct. You can see that it's almost aneurysmal here. And the RV is quite dilated. When we put color across it, you see that there's turbulent flow in the apex. That's very unusual. So when you start trying to sweep and interrogate further, we can see that there's actually flow from the left ventricle into the right ventricle just based on the color Doppler profile. And when you use contrast, first you have a pacification of the right ventricle, and then you have this large, very early pacification of the left ventricle. So yes, that's diagnostic of ventricular septal rupture. Okay, finally we'll end off with free wall ruptures. So they can be both contained and uncontained. So when they're contained, it's referred to as a pseudoaneurysm, and that's different from a normal aneurysm in that you have you have a total defect in the myocardium that leads to a cavity being formed, and that's contained by a complex of pericardium and clot, which is different from a normal aneurysm where the left ventricle wall is still intact. The mortality is high, but not quite as high as the other ones. Still, something needs to be done for these patients, surgery. So when you, because they have a much higher risk of rupture, that's why you try to get them assessed. The main echocardiographic features that we're looking for are a narrowed base. So the base here is quite narrow compared to the LV aneurysm. And we're looking for what's referred to often as the to and fro flow into the cavity. So we're looking for color that color Doppler across into the cavity, and we're looking for contrast that goes in and out. So this is an example. We have a peristernal long axis here, and we can see that the left ventricular function is quite reduced, and there's something unusual here. So when we try to interrogate further in the short axis, we can see a very large cavity here, and it's essentially a localized pericardial effusion. It's not present in the other segments. You can also see that the posterior and the posterior medial, the infroseptal, are quite hypokinetic. And when you try to interrogate with color Doppler, you can see that there's flow going into the cavity and back. And then when you add contrast, first there's contrast present in the left ventricle, then slowly you start to see it going into the cavities, and then you can also see it going back into the cavity. So that's a to and fro, and that's diagnostic. All right. So finally, we'll just quickly touch on uncontained free wall ruptures. So these have a much lower incidence, but an extremely high mortality, more than 60% in the shock registry. They're typically anterior or lateral wall infarcts, and they're associated with fibrinolysis. The main features that we're looking for here are tamponade and color Doppler or contrast into the pericardial effusion that's circumferential. So I couldn't find any example of this. This is just an image showcasing color Doppler across the right ventricle, in this case, into the pericardial infusion space. So this is with collapse essentially, and yeah, this is an example of free wall rupture. I just want to make one note about pericardial effusions after STEMI though. So there is a differential for this, and you can have a peri-infarct pericarditis, you can have free wall ruptures, aortic dissection, it can be iatrogenic from coronary intervention. So you'd think that pericardial effusions are fairly nonspecific after a STEMI, but that's not necessarily true. So this is a study that was done in 2010, published in Circulation, that was the largest I could find, that was looking at all STEMI presentations and looking at whether they had pericardial effusions and seeing if there was an association with 30-day mortality. So on the horizontal, y-axis here, we have the percentage of patients. On the x-axis, we have all the different categories that this study looked at. So on the left, we have no pericardial effusions, small pericardial effusions, moderate pericardial effusions without any features of cardiac tamponade. Then there's patients that had cardiac tamponade on presentation without cardiac arrest, END referring to electromechanical dissociation, which is PEA arrest. And finally, cardiac tamponade with arrest. So the ones with cardiac tamponade, they're as expected. These are patients that have, so the white boxes here represent 30-day mortality. So 85% of patients that had cardiac tamponade with arrest they died within 30 days. And the majority, almost all of them, were from free wall rupture, which is expected. When you look at patients that had cardiac tamponade without arrest initially, 14% of this group died, and half of those were from free wall rupture. What's interesting, though, is this group right here, the moderate pericardial effusions. So these patients did not have any features of cardiac tamponade on presentation. The 30-day mortality for these patients was 17%. And when you look at the proportion that were from free wall rupture, it was about half of them. And then they tried to compare a matched group of patients without any pericardial effusion, and the mortality, the baseline mortality was about 6%. So basically, what this is showing is that when patients present with STEMI and there's a moderate sized pericardial effusion, even if there's no tamponade, you should be very suspicious and try to investigate for wall rupture. Okay, so that's free wall ruptures. Just some takeaways from the talk. So I tried to show that management differs for each kind of mechanical complication that you encounter. Echo is a really useful tool in not only diagnosing but also managing these patients. And sometimes it's purely an echocardiographic diagnosis in the case of LVOT obstruction. Rupture complications, they have a very, very poor prognosis, and it's very important to recognize these patients early and to get cardiac surgery involved. If you see a moderate-sized pericardial effusion after a STEMI, it should prompt further investigation. That's my talk. Thanks, everyone.
So thank you, Mian, Dr. Mian, and just want to mention one thing that was interesting in terms of what you brought up is the McConnell sign. So Dr. McConnell was a fellow at Brigham and Women's Hospital, working with Dr. Pat Cum, who came up with that sign. Initially, it was described for acute pulmonary embolism. So this is most commonly associated with. But if you actually read the paper, it was actually matched against a group of pulmonary hypertension. So on the other hand, we do see sometimes McConnell sign in RV infarct. In fact, in that particular paper, the third group in that paper was against RV infarction, and they couldn't tell whether it's pulmonary embolism or RV infarct. So it's not unreasonable to think about that in the right context. But typically, you hear about McConnell sign that's actually associated with acute pulmonary embolism instead. So anyway, it's interesting that you brought up in this context.
Yeah, it's a marker of an acute process, but if it goes along with other things that you see, then it's just important.
So maybe I'll start the first question. So what do you think about the utility of POCUS in this particular setting? Should everyone who comes in with suspicion of SC lesion MI, non-SC lesion MI, should they all get a POCUS as part of your physical examination?
Yeah, I mean, I think it's a very, as we get in clinical practice, it's a very easy thing to do just for screening. There are certain features that we look for, and if they're present, it's highly suggestive of something going on. So, I mean, back in Western, we pretty much focus everybody that comes in for a STEMI anyway. And I think it's a useful thing to do for sure. Yeah, it's you question about like in that setting, when you have a STEMI presentation, there's a lot of things going on, and you're trying to get into the cath lab. Usually the focus happens after the coronary intervention, but it's a good point whether we should do that even before the cath lab.
There was some people in auto were thinking about looking at this. I don't think it's been published yet, but like actually looking at what percentage of the time a focus pre-cath changes decision making or changes management. Like the way it works at some centers, auto being one of them, is where patients all land in the STEMI bay or seen by cardiology resident before they go for cath. Nobody goes to a cath table without a cardiology resident having seen them. And sometimes it changes management, right? Like if you look for a patient who's acutely infarcting and they have a moderate precardial effusion, and you know that cardiac surgery might be involved, you might not give them a second antiplatelet, right? Or you might change their acute management. So it might be worth looking at. Just like quantifying what percentage of the time it changes management.
Yeah, I would also further add physical exam, although I loved it really. It's often very deceptive in a situation of acute myocardial infarction. The reason is with papillary muscle rupture that leads to MR. I mean, it's very frequently missed because it's such an acute thing, and also the murmur is very short. So often it's actually underwhelming in terms of the murmur of the ones that I've examined. So having that is actually useful. Looking for pericardial effusions is very useful in POCUS, given the risk that you actually presented, and sometimes the VSD or ventricular septal rupture rather is very serpiginous, meaning that it actually travels around the tract, which on physical exams sometimes they're not that obvious initially, and they become obvious later with a systolic murmur or very loud murmur, but it doesn't occur right away. So it's very deceptive. So I think it's not unreasonable. In fact, it's probably recommended to actually POCUS everyone as part of your acute myocardial infarction assessment. Yeah. But we need to get everyone to be good at POCUS at the trainee level. This is actually our challenge right now, because most people in most programs have anywhere between 4 to 8 hours of POCUS. At the medical student level or internal medicine level. So we all know that it takes a lot longer than that to acquire really good scanning skills. All the cardiology residents would agree with that, right? It takes a while. It doesn't take 4 to 8 hours. It takes quite a bit more than that. Okay.